Thank you very much. I would like to thank the organizers for giving me the honor to talk after the Grand Master of Bifurcations, uh, Thierry Lefebvre, um, who actually covered the subject in an incredible way. But you know, it's my job to be the contra, so I'll do my best. Um, uh, I was very lucky because I met Imad last week in Dubai in the Gulf Interventional System, and he was doing a similar debate, and he gave me some new slides, and I acknowledge that that was his first slide. As you saw all through the presentations today, bifurcation lesions are a conundrum. I mean, it's a big issue in our minds, and tons of bifurcation techniques which confuse everybody. And the big thing is basically you push stuff to the side branch, and that is the problem. Dr. Lefebvre just showed us very quickly, showed us very well what POT is, so I'm not going to go through it. But I just want to remind you that you can't escape doing bifurcations. That's why you have to learn it very well. 20% of your cases are going to be bifurcations. We have no dependable strategy, and as Ashraf Rida just said, we have no single technique which works. We have lack of large randomized studies and lot of risk of periprocedural complications, high risk stenosis, especially in the side branch. Size of vessels is important. Plaque distribution is important and is very variable. My point is I'm trying to convince you as we go through that every case is so individually different that you cannot have a strategy that's going to work all the time, even POT and final kissing, and I'll try to convince you with that. The extent of your side branch disease will be different. Angles are a whole variety of angles. And if you don't do your job properly, you'll have a high risk of stent thrombosis. And we have today, with us today, we're lucky, we have some of the best bifurcation operators on the planet who came from the Institut de Paris Sud. Thierry Lefebvre has laid the foundation for a lot of our knowledge today. And PCI techniques are actually based on personal experiences from skilled operators. So they might show you something which looks so simple, and then you might come and try and do it, and you might not be able to recross, and you might not do it. And I'll show you now how I think sometimes you can avoid complex techniques. Again, you have to look at what is your bifurcation, is it left main or not, and what imaging modalities are you going to use. We just saw that they were using the OCT. Do you have OCT? Are you going to use IVUS? Are you going to use FFR? Are you going to use QCA or nothing? And of course, what devices you're going to use. A simple stenting is basically stenting across a side branch with one stent, and complex stenting is all the variety of techniques that we've been talking about. So are all jailed side branches important? I mean, if you jail a side branch and it looks bad on angiography, actually about a quarter of those side branches, just over a quarter of those side branches are absolutely fine if you FFR them. So you might end up doing, this is the first situation where a kiss might not be necessary, is if you FFR the ostium of the jailed side branch, which is not looking good, and you find that the FFR is 0.9, which is about 27% of your cases, then you can probably leave it alone because you might not want to distort the stent. Should you predilate the side branch before, if you plan a provisional stent and you have a side branch, should you predilate it or should you leave it alone? An unanswerable question. The disadvantage of predilating is you might hurt the endothelium and you might cause unnecessary trauma or even dissect it. Of course, the advantages are more because you will assess how the ostium will behave. You'll optimize the subsequent stent expansion. We just saw the calcific lesion in the live case. You'll better evaluate the most appropriate stenting strategy, and you might facilitate subsequent rewiring if your stenosis is more than 90%. And you may reduce the potential for ischemia during the procedure. So it's, again, a personal choice. If you're stenting across a side branch, you have the option, as Thierry Lefebvre just showed us in his last slides, to either do a kissing blunt inflation afterwards or to leave it alone. It's a question which has not been answered. Most people, even though he showed us this beautiful video, but a lot of people, as we saw, less than 30% will do it. Most people will leave a side branch which is open with a stent across it without opening the struts and without doing a kissing. Even with a crossover left main on a circumflex. You might actually, as in this case shows, that you might actually, this was a John Ormiston old one, which showed how stent deformation can happen. And here's before and after a kissing balloon, and how stent deformity could predispose to stent thrombosis or restenosis or limit subsequent wiring. So how can you minimize, I mean, if that is the beauty of the kissing balloon after the crush, and you see the ostium of the side branch is looking bad here, and of course after the kissing balloon in a crush, it looks good. So kissing balloon after crush is good, and it was claimed to be the most important step, even though it's a little bit difficult. And this is, Thierry showed us this very well. I'm not going to repeat the slides, but you need to know your Murray's law, your Hassab-Kassab law, and your Finney law. And you need to be able to calculate the size of your proximal balloon and the length, as Khamis was pointing out. You should have short stocks or make sure and use your pot. So if you follow the proper technique, you might need to do less optimization afterwards. If you make any of those two mistakes, for instance, if you're doing a tap and you leave a gap or you put your stent too deep inside, optimization becomes much more important. If you manage to do your technique perfectly, we'll see now, you might get away with less optimization. The same for crush. Is it more important to perform a final kissing balloon after a crush, after knowing all the steps automatically, or is it more important to perform your crush pinpointly accurate? Okay, so obviously, if you perform the crush on the left and you leave 3 layers of a long overlap, you really do need to pot very much, and you really do need to do a final kissing balloon very much. What about if you perform a perfect mini crush, like the one on the right? You might actually image after that one and find that things are looking good. Now, if you image after the one on the right and you find that everything looks perfect and your FFR wire is there and there's no ischemia, are you still going to do a final kissing balloon? Maybe. Side branch stent under expansion after the crush is more at the ostium of the side branch, and that is what you should focus. And if you're not using imaging, then you should probably routinely do stuff. But if you're using imaging and you can see, that might save you subsequent steps. This is, on the left, is a proper crush apposition, where all the struts are against the wall. On the right are struts which are left obstructing with malapposition. It's actually common to leave this, and if you don't pot and you don't kiss, you might leave it. But again, if you image and you find after you've done your bifurcation technique that things are looking like this, you might not need to do further steps. So it all depends if you have used the proper size of the balloons, if you have properly placed your stents without too much overlap or not. One of the big beauties of angioplasty is that human beings are so resilient that it's forgiving. With drug-eluting stents, we make mistakes, and Thierry Lefebvre has just shown us that in the best trials, the super techniques are only used between 20 and 30% of the time, yet the other 70% of people who didn't get those techniques did not die and did not even get restenosis. So a lot of patients that we leave with imperfect techniques probably get away with it. In all complex stenting technique, there is at least one step of kissing balloons. So wherever that comes in tap, in culotte, in DK crush or mini crush, at some point you will kiss. but we're talking about the final kissing today. So in simple stenting, I won't discuss that. Kissing reduces jailing struts at side branch ostium. We've seen that with non-final kissing and kissing, so kissing is better. Of course, if you have less malapposition, you'll have less thrombus formation. And we have data from WHO in Korea that kissing improves the FFR at the side branch. So kissing balloon is good. Should we always do it? Actually, no. You shouldn't always do it because it's not perfect, at least in conventional stents, and it has some limitations. A kissing balloon here has caused stent displacement. Look at the proximal part of the stent, and in this case, which was not a two-stent technique, the kissing balloon actually, I would say, harmed the patient. It also depends where you're crossing. Are you crossing proximally or distally? And what stent design are you crossing? Are you crossing a Zients? Or are you crossing or zero? All those different stents have different links, and when you cross and where you fix is different. On the left here is a recrossed wire distally, and here is a recrossed wire proximally, and look after the kissing balloon. In both here, the stent deformation on the side, and here, when you cross proximally, as being told, many remain jailed struts in the inferior part. This is an interesting slide from Murasato, where he shows us if your wires and balloons and you're in perfect position, your kiss will result in a good result. However, this might not be the case. And this is not something that you control very well. And you could end up with all sorts of shapes at the bottom. On the bottom left is a perfect kiss. The ones on the right are less perfect. So you might actually cause more stent distortion by kissing. We do know that in the Excel trial, kissing balloons actually made no difference. The performance of final and kissing balloon after PCI of left main bifurcations was not associated with improved 4-year clinical outcome, regardless of whether 1 or 2 stents were implanted, and they asked for randomized trials for the kissing balloon. And this is a recent trial, 2019, the Nishida trial, which looked at the prognostic impact of final kissing balloon technique after crossover stenting for left main from the left main registry. And again, there was no difference when they kissed or they did not kiss in the left main. Stent sizing is extremely important. If you are sloppy about your stent size, you always need to do optimization. You should always aim for the distal reference and pot. I recommend pot, but not necessarily final kissing. And these are the alternatives to final kissing, which are pot or pot side branch or side branch pot or pot side branch pot. And the COBIS 2 was well said. This is the fractal coronary bifurcation bench testing, which showed the comparative analysis of sequential pot versus kissing in provisional bifurcation strategies, comparing 6 strategies. And the conclusion was that in comparison with the 5 other techniques, the repot sequence significantly optimized the final result, maintaining the circular geometry, and that it was better than final kissing balloon. This is the benefit. This was the article about it, showing how you do it. Before stent implantation was the OCT run 1, then the stent, OCT run 2, initial pot, side branch inflation, final pot, and final result. And the conclusion was that the clinical study of large sample of coronary bifurcation with OCT analysis showed that the benefit of the repot sequence in provisional stenting replicates the in vivo excellent geometric results, showing that it's easy to do with a good outcome. So my conclusion is that final kissing balloon or pot options are still used for the majority of two-stent techniques in bifurcations, but that should not be an absolute rule. In some cases, you may actually distort stents and cause future events. You should pay attention to precise sizing and precise placement, paying critical attention to angles, degrees of metal overlap, using imaging, and occasionally physiology should determine the need for a final kissing balloon or not. It should not just be done in a blind fashion on top of poorly sized stents with poor expansion and long overlap. Understanding the anatomy and the physics of bifurcations and angles and meticulous attention to technique Meticulous attention to technique and using imaging can make final kissing balloon less important to outcomes, as seen in the Excel trial. And my conclusion in this debate is you do not need to final kiss balloon in every case of two-stent technique, because you can do a pot, side branch, repot. In Arabic, we have a famous proverb saying, "Hafiz mish fahm," who's the person who does something in a very robotic way, knowing all the steps. And I see all my fellows carrying little agendas with diagrams like the one on the right to know the steps of T, mini crush, a tap, DK crush, blah, blah, blah. When somebody does every single step when not needed, could be even possibly harmful. So I would say don't be that in bifurcation lesion PCI. Those lesions require much more than having a diagram of the steps. And again, I'm so grateful to the committee for inviting Professors Lefebvre and Hoas from Paris. Thank you very much.